I'm Arlene Siefker-Radtke. I'm a professor of genitourinary medical oncology at the University of Texas, MD Anderson Cancer Center in Houston, Texas. Well, there's been a lot of excitement about the development of FGFR3 inhibitors in bladder cancer, with the recent approval of erdafitinib this year as a treatment for patients with mutant urothelial cancer. Vofatamab is an antibody that targets both mutant FGFR3, but also has activity against wild-type FGFR3. And when we look at where FGFR3 amplifications and alterations lie, they appear to associate with an immunologically cold tumor. There's been some debate. Do these cold tumors respond as well to immune checkpoint inhibitors? Some evidence suggests they may not respond as well and may need additional strategies to best impact the patient. Although others have argued you still see activity with an immune checkpoint inhibitor in this population. The goal of this clinical trial was to build on experience with FGF inhibition by combining this antibody with the immune checkpoint inhibitor pembrolizumab to see if we had an active and tolerable regimen. This therapy was also built as a biopsy-driven trial to try to understand the biology of these potentially immunologically cold tumors. On this biopsy-driven trial, looking at the mutant fusion FGFR3 patients, we've enrolled 7 patients on the cohort so far. Enrollment is still accruing. Of those 7 patients, 3 have had an objective response, giving us an objective response rate of about 43%. In addition, when we looked at the wild-type cohort, we were intrigued to see clinical activity there as well, with responses occurring in 5 out of 15 patients who were enrolled to the trial. We went back and looked at the biomarkers associated with these patients, and we're intrigued to note that the majority of these responses were observed in the luminal subtype of bladder cancer, which is typically considered a more immunologically cold tumor. When we looked at post-vofatamab biopsies, so these were biopsies done prior to treatment with pembrolizumab, we did see enrichment of markers associated with inflammation and an inflammatory response. Further work is currently being planned to better understand this biology and accrue more patients in the hopes of understanding how an FGFR3 targeted agent may impact the immune response in bladder cancer. Well, there certainly have been toxicities observed with the oral agents, including hyperphosphatemia, which has been limiting for some of the FGFR targeted agents developed to date. Erdafitinib appeared to have a better phosphate level, but there are other toxicities, including hand-foot syndrome and the potential for ocular toxicity that so far has been managed well. We looked for these toxicities with vofatamab, which is an antibody, and did not see hyperphosphatemia, and overall it was very well tolerated. So if we can confirm clinical activity in a larger group of patients, it could be a potentially attractive strategy as a means of targeting FGFR3 and potentially minimizing toxicity to patients. The sample size is still small, which is one of the limitations of this work. The mutant fusion cohort is still accruing patients. I think it would be helpful to accrue more wild-type patients as well to help us better understand the biology associated with FGFR3 targeting in combination with immune checkpoint inhibition.